Welcome to YouTube lessons on interpretation of ECGs. I am Dr. Mrs. D.S. Gunawardena. I have been working attached to National Hospital Kandy, Sri Lanka since year 2003. Since then, I have been conducting classes on interpretation of ECGs to medical officers, medical students, and postgraduate trainees. Textbook ECGs in Clinical Practice was written and published by me in year 2019, which contains both of my teaching and clinical experience. Material in this YouTube lecture series are from textbook ECGs in Clinical Practice. I hope that this lecture series will be useful for you to interpret ECGs. Lesson 12. Analysis of Atrial Tachyarrhythmias. In lesson 5, we discussed the classification of arrhythmias. According to the classification of arrhythmias, basically arrhythmias are divided into tachyarrhythmias and bradyarrhythmias. Tachyarrhythmias are further classified according to RR interval and QRS duration. Therefore, in lesson 5, we categorized tachyarrhythmias into 4 subgroups. Those are regular narrow complex tachycardia, regular broad complex tachycardia, irregular narrow complex tachycardia, and irregular broad complex tachycardia. When we were medical students, tachyarrhythmias were subdivided into 2 groups. Those are supraventricular tachycardia and ventricular tachyarrhythmia. Supraventricular tachycardia means tachyarrhythmia originating either from SA node, AV node, or from atria. Ventricular tachyarrhythmias mean tachyarrhythmias which originates from ventricles. Now let's see what is the definition of atrial tachyarrhythmias. Atrial tachyarrhythmias are defined as tachyarrhythmias which originate from atrial cavities, but not from SA node or from AV node. Examples of atrial tachyarrhythmias are atrial fibrillation, atrial flutter, and atrial tachycardia. As you know, in atrial fibrillation, if you look at atria, it has a tingling worm appearance. Electrical activities are going on at a speed of 600 wavelets per minute within atria during atrial fibrillation. There is no proper contraction. During atrial flutter, atria beat at a rate of 250 beats per minute to 300 beats per minute. During atrial tachycardia, atria beat at a rate of 100 beats per minute to 300 beats per minute. This diagram shows the heart top chambers and bottom chambers. This is the SA node, this is the AV node, this is the rest of the conduction system, 2 atria and ventricles. Now, as we discussed, atrial tachyarrhythmias include atrial flutter, atrial fibrillation, and atrial tachycardia. During atrial fibrillation, on surface ECG, you can see irregular baseline. These irregularities consist of very low amplitude undulations. During atrial flutter, surface ECG shows a sawtooth appearance. It looks like an artistic drawing compared with atrial fibrillatory waves seen on the baseline. Atrial fibrillatory waves seen on baseline looks like something written by a patient with fine tremors. In atrial tachycardia, you can see very fast, regular atrial activities, abnormal P waves with isoelectric baseline, and there is fairly organized contraction of atria occur during atrial tachycardia. In all these three conditions, atria are in tachycardia. In atrial tachyarrhythmias, the ventricular rate is decided by the AV node conduction velocity. During sinus rhythm and during normal cardiac cycle, the AV node creates a physiological AV delay. As you know, because of this physiological AV delay and the time taken to depolarize atria produces normal PR interval. Because of this physiological AV delay, AV node can filter unwanted atrial impulses as well. Therefore, this physiological AV delay protects ventricles from unwanted atrial impulses. When the AV node conduction is normal, that means if the PR interval is normal, when there is atrial tachyarrhythmias at the atrial level, the ventricular rate can go above 140 beats per minute. It may reach 300 beats per minute, depending on the conduction ability of the AV node of given patient. What should be the ventricular rate when there is AV node dysfunction? When there is AV node dysfunction, conduction velocity of the AV node will drop. Therefore, though there are atrial tachyarrhythmias going on, the ventricular rate will drop below 140 beats per minute. Depending on the degree of AV node dysfunction, sometimes patient may develop bradycardia. Therefore, in atrial tachyarrhythmias in a patient with AV nodal dysfunction, atria are in tachycardia, either atrial fibrillation, atrial flutter, or atrial tachycardia. Ventricles show comparatively slow ventricular rate or even bradycardia. Now, let's discuss this ECG. It shows it is a 12 lead ECG. If you analyze this ECG, you can see irregular RR intervals. Irregular RR intervals. QRS complexes are narrow. And in addition to that, on the baseline, you can see irregularities, which is more marked in lead V1. Ventricular rate is not that fast. It's around 100 to 110 beats per minute. So this is a case of atrial fibrillation with controlled ventricular rate. Now, this patient presented to the ETU with fast palpitation and breathlessness. Then the patient was managed at the ETU with DC shocks, amiodarone, and a low dose of beta blockers. With this treatment, ventricular rate dropped to 100 to 110 beats per minute. So that is called atrial fibrillation with controlled ventricular rate. In this case, at the atrial level, the atrial fibrillation is going on, but we have controlled the patient's ventricular rate. If we analyze this rhythm strip of V1, V2, V3, again you can see irregular narrow complex rhythm with rate around 50 to 60, that is ventricular rate around 50 to 60. On the baseline, you can see very fine irregularities. Those are the atrial fibrillatory waves. Therefore, this rhythm strip shows atrial fibrillation with clinically significant bradycardia. This patient was otherwise healthy, admitted with 2 syncopal episodes, and this is his rhythm strip of V1 to V3. Patient was not on any treatment, electrolytes are normal. In this case, we made the diagnosis of tachybrady syndrome because at the atrial level, there is atrial fibrillation, that is atrial tachyarrhythmia, and at the ventricular level, there is bradycardia. The electrophysiological mechanism of this is that in a patient with SA node dysfunction, they are prone to develop atrial tachyarrhythmia. So this patient has developed atrial fibrillation. The same disease process can affect the AV node as well. Therefore, there is high-grade variable AV block giving rise to bradycardia. This patient was managed with a permanent pacing. This rhythm strip again, lead 1, 2, 3. It shows regular RR interval with clinically significant bradycardia of around 40 beats per minute. On the baseline, you can't see regular P waves, but you can see low amplitude irregularities. These are the atrial fibrillatory waves. When there is atrial fibrillation going on, this patient has coexisting complete AV node failure, that is complete heart block. Therefore, none of the atrial fibrillatory waves can enter into the ventricle. So this is the escape rhythm which originates from probably the bundle of his. In lesson 5, we discussed bradyarrhythmias and complete heart block. There we discussed the escape rhythm which originate from bundle of his. This is the only condition in which ventricular rate becomes regular during atrial fibrillation. That is atrial fibrillation with complete heart. When you analyze the ECG, you may find the cause of both of these atrial fibrillation and complete heart block. You may see evidence of ischemic heart disease. As an example, if patient develops acute ST elevated inferior myocardial infarction, total occlusion of the coronary artery is above the AV nodal branch of the right coronary artery. Patient will develop complete heart block and ischemia may induce atrial fibrillation. Now, this rhythm strip, this include lead 1, lead 2 and lead 3. Again, regular narrow complex tachycardia at a speed of 120. On the baseline, if you ignore these QRS complexes, you can see saw-tooth appearance. Saw-tooth appearance. So, this is a case of atrial flutter. As RR intervals are regular and there is tachycardia, we have to consider the possibility of atrial flutter with 2:1 AV block. In this case, as the ventricular rate is 124 beats per minute, the atrial flutter rate should be double of this, that is around 250 beats per minute. This 2:1 AV block is functional. Once we control the rhythm and patient is in sinus rhythm, during which there is no 2:1 AV block. Only during the atrial flutter, you can see this functional 2:1 AV block. Therefore, you can manage this patient with either rhythm controlling or rate controlling drugs. Or if the patient is hemodynamically unstable, you can manage the patient with direct current cardioversion. Let's analyze this ECG with limb leads. If you analyze the rhythm strip, you can see a paroxysm of tachyarrhythmia. It terminates spontaneously. Then you can see 2 sinus beats. Again, paroxysm of tachyarrhythmia starts. It's a regular narrow complex tachycardia at a rate of 150 beats per minute. Each QRS complex is preceded by inverted P wave. These P waves have bird's beak appearance, abnormal P waves. During sinus rhythm, the P wave in lead 2 should have positive polarity. But in this case, P wave has negative polarity. Therefore, this ECG is not in sinus rhythm. This is atrial tachyarrhythmia with 1:1 AV conduction. That means each atrial P wave is conducted into the ventricles. Therefore, that is called 1:1 AV conduction. The atrial rate is 150. The ventricular rate is also 150. The diagnosis is atrial tachycardia with 1:1 AV conduction. This is V1 rhythm strip. You can see it is abnormal and there is significant bradycardia. Rate is around 1, 2, 3, 4, 5, 60 beats per minute. On the baseline, you can see P waves. These are biphasic P waves at a rate of 300 beats per minute. So at the level of atria, the atrial rate is 300 beats per minute, but the ventricular rate is slow. There is significant bradycardia, and there is some irregularity is also seen. So this is atrial tachycardia with high-grade variable AV block. So what is the electrophysiological mechanism? This patient has developed atrial tachycardia, and simultaneously patient has clinically significant AV node dysfunction. If patient is not already on rate controlling drugs or antiarrhythmic drugs, this could be a case of tachybrady syndrome. Now let's see how to tell the diagnosis of atrial tachyarrhythmias. The diagnosis of atrial tachyarrhythmias should include type of atrial tachyarrhythmia. It can be atrial fibrillation, atrial flutter, or atrial tachycardia. And in addition to that, you must mention the ventricular rate, because the ventricular rate may be fast or it can be very low. There can be clinically significant bradycardia depending on the AV node conduction. How to manage patients with atrial tachyarrhythmias? In the presence of atrial tachyarrhythmias, ventricular rate should be normalized. If there is bradycardia, the bradycardia should be managed. If there is tachycardia, tachycardia should be managed. In addition to that, the ongoing atrial tachyarrhythmia should be managed. That means the rhythm control. Rhythm control. Management of bradycardia. During atrial tachyarrhythmias, if the ventricular rate is slow and if the patient is hemodynamically unstable, patient will need pacing. And the pacing rate should be maintained around 80 to 100 beats per minute. If facilities for pacing
are not available,
until the patient is transferred to a center where pacing is available, patient may be able to manage with inotropes. What you should remember is that during atrial tachyarrhythmias, if there is clinically significant bradycardia, you should avoid direct current cardioversion, use of antiarrhythmic drugs, and use of rate controlling drugs till pacing is done. If you use one of these treatment modalities in the presence of clinically significant bradycardia in a patient with atrial tachyarrhythmias, patient may develop asystole. As I mentioned earlier, in atrial tachyarrhythmias, if the ventricular rate is naturally slow, possibility of tachybrady syndrome should be suspected. Therefore, avoid pharmacotherapy, rate controlling drugs and antiarrhythmic drugs, and direct current cardioversion without ventricular pacing. During atrial tachyarrhythmia, if the ventricular rate is fast, you can use one of these treatment modalities. Direct current cardioversion if the patient is hemodynamically unstable, antiarrhythmic drugs, or rate controlling drugs. Now we learned about how to manage the ventricular rate during atrial tachyarrhythmia. Then the next step is the management of ongoing atrial tachyarrhythmia. That means We have to revert atrial tachyarrhythmia into sinus rhythm in some patients, in selected patients, if it is indicated. Direct current DC, direct current cardioversion, antiarrhythmic drugs, and radio frequency ablation are useful to maintain the sinus rhythm. These treatment methods are called rhythm control treatment methods. If I summarize, during atrial tachyarrhythmias, the ventricular rate may vary from clinically significant bradycardia to very fast ventricular rate. It may go even up to 300 beats per minute. The management depends on the ventricular rate, and it should be stabilized while managing the ongoing atrial tachyarrhythmias. We have come to the end of the lecture. Thank you.